Dr. Tamiko Katsumoto swept us away when she lit up the stage at Stanford's Health Matters Summit.
And I'm so looking forward to speaking with you today about something that is near and dear to my heart, which is food's protective power against disease. This hits close to home for me because I'm a rheumatologist and I deal with chronic inflammation all the time.
She is both a physician and a scientist, so we took a little peek at her patient ratings. What? Who gets across-the-board 5-star patient reviews and over-the-top positive comments, especially when working with really hard problems like arthritis? 2 weeks ago, we published an interview with another physician scientist, Dr. Sean Spencer, and the comment section went crazy with requests for him to come back for a second interview. He was focused on the gut and the very modern side effects of antibiotics and probiotic pills. Tamiko is focused on joint inflammation and the very modern side effects of industrial chemicals and plastics. And yet, in a soup of factors, they both landed on one factor to rule them all.
Good to see you. Oh my
Hello,
God.
how are you?
Wait, what's going on with this camera?
We roll cameras, that's what we do.
Chris is as we're like freezing in California.
Tell us about your background, Tamiko.
I grew up in the Bay Area. I ended up doing all of my medical training at UC San Francisco. I was there for 17 years. Ended up actually doing basic science. I started out in the lab in immunology. I worked with Art Weiss, who's an incredible scientist, learned a lot about the immune system, but realized I wanted to make a bigger impact, and that's what prompted me to go to industry. So I ended up going to Genentech and doing drug development for a few years. Learned a ton about big cross-functional teams, working globally, really making things happen. And I think what I really missed was patients and patient care, the academic world. And that's what brought me back, which is where I've landed here at Stanford. Got here in 2018 and have been really excited to be part of the Stanford Medical Center, where I've found myself working on immuno-oncology, working on what are called checkpoint inhibitor complications, learning that diet actually plays a big role. And I've started to realize just how pivotal diet is in terms of modulating a lot of our immune system inflammatory responses to different things. As a rheumatologist, obviously that makes a big difference. I work with patients that have autoimmune diseases, that have a lot of arthritis, systemic inflammation, and I've really come to appreciate the fact that food is medicine and the fact that food can modulate people's inflammatory levels. And so that's what's really guided me. I've had a very circuitous path coming here, but as I've kind of found my way, I've learned just how impactful food is, and I've really made this a big part of my career focus, is talking about diet, understanding what we can do to modulate diet for our patients and for our planet.
Incredible. And these patients, what do you see in them when they come to you with like arthritis or other inflammatory issues or autoimmune conditions? Do you advocate they switch to a plant-based diet, go more plant forward, and then what happens to them?
So yes, it's so interesting. I think that as we're learning more and more about the microbiome and how important it is to foster a healthy microbiome with a lot of diverse bugs and whatnot, and how important fiber is in terms of maintaining our gut immune system, calming down the immune system so that we don't have overactivated immunity, I've learned that by moving patients towards more plant-centered diets, they often will get better. And it's been really striking. There's been so much emphasis in our current culture about let's focus on protein, and people need meat to have our protein. And it's so interesting because there have been cases where specifically people have adhered to a very highly meat-centered diet and their joints flare. And I mean, I can think of 2 patients in particular who came to me, and as the minute they started giving up red meat in particular was really bad, but as they started moving more towards plants, their joints got better. And so I was so excited when this incredible study came out from the Netherlands. Our Dutch colleagues did this study that was called Plants for Joints. And I thought this was really a beautiful lifestyle medicine randomized controlled trial where they basically randomized people to standard of care versus a lifestyle intervention that was guided by the 6 pillars of lifestyle medicine. The first one, and probably the most important one, being diet. They put patients on a whole food, meaning no processed, no ultra-processed foods, whole food, plant-based diet. So essentially it was vegan. They also made sure people had good exercise, plenty of sleep, low stress, sense of community, and then avoidance of risky substances. So those are the key 6 pillars of lifestyle medicine. So they basically randomized these patients to a lifestyle medicine arm versus a control arm. And what they found in 16 weeks, even starting at 8 weeks, they started to see differences. People that had rheumatoid arthritis and metabolic associated osteoarthritis started to improve substantially. Their joint pain got better. There was an objective joint score called the DAS-28 that improved substantially. In fact, it was really quite striking. I mean, it looked similar to what we see in drug company studies. It was not trivial and very attention grabbing. And so when I saw this study, I recognized what I've seen in the clinic really does hold some truth for a lot of patients, where by moving towards a plant-centered diet, they do calm down their inflammation, which was really quite striking, as well as incorporating a lot of other lifestyle-based approaches into their life. So I think there's been really a lot more attention now focusing on lifestyle medicine. And I'm so excited that I just recently got board certified in lifestyle medicine, which has been great. I think that if there's a way we can incorporate this more into our regular practices and really spread the good word, I think this is going to be super impactful for medicine in general.
Absolutely. Yeah. And do you have any patients who've gone like full carnivore?
It's so interesting you asked that. I think that I have had some patients that have been very carnivore-centric. I'm not sure that anyone has confessed to me that they're full carnivore, but I've definitely heard that people say, oh, this makes me feel better. This is definitely a helpful thing. I think that essentially what happens is by going exclusively with meat, you eliminate a lot of things that may be causing sensitivities, because your gut microbiome may not be primed, right, to be able to accommodate a lot of these things like grains and sugars and whatnot. But simply by limiting to one item, that may, in a temporary setting, may lead to relief. But in the long term, I actually think it's really terrible for gut health, because our guts rely so much on fiber. Our guts, we need to have that very nice protective epithelial lining and a nice mucus lining, which is produced by the epithelium. And then basically that protects us from all the bacteria that are living in our gut. And those gut bacteria feed off of fiber. And if you don't have fiber, which by the way, animal like meats don't have, you're not able to feed those gut bacteria. And the gut bacteria that you do end up cultivating end up being more problematic. So for example, more associated with cardiovascular disease, more associated with metabolites like trimethylamine oxide, which has been very clearly associated with cardiovascular disease. There was a recent study that came out in Nature Medicine, published by the Zoe Science and Nutrition Group, 21,000 people that they studied. And they looked at dietary patterns. And what was super interesting is they compared vegan versus omnivore. And even in the vegans compared to the omnivores, they saw an enrichment of a lot of these healthy bacteria that tend to produce many more of the short-chain fatty acids. So short-chain fatty acids are metabolites where some of these good bacteria end up fermenting fiber and producing these short-chain fatty acids that are super important in gut homeostasis. These metabolites kind of calm down the immune system, calm down the T cells, actually encourage T regulatory cells, which are sort of the counterbalance of the immune system that keep inflammation at bay. And so it was so fascinating that they found, again, 21,000 people, lots of data, but the vegan diets, the more plant-centered diets, had enrichment of these healthier bacteria. And the omnivore diets that were more rich in meat had some of these less healthy bacteria that tended not to produce the short-chain fatty acids as much. So I think there's biologic rationale for why plant-centered diets can be so healthful. So not only are they better for cardiovascular disease, for diabetes, preventing even dementia. Dean Ornish hit an incredible home run with a lifestyle-centered intervention looking at mild cognitive impairment. And he showed that there was, in fact, improvement in a short-term 20-week-long study by going with whole food plant-based diets, as well as lifestyle. Similarly, in arthritis, I think it's the same concept. The same themes hold true, that eating more plants tends to calm down your inflammatory response.
Very cool. And what about food intolerances? I'm sure that a lot of people come to you with food intolerances. When they change their diet, does that change as well?
Food intolerances is tricky, and I cannot profess to have the answer for this question for everybody. The key point is there's not a one-size-fits-all diet. I think everyone needs to kind of modulate based on what works for them. My understanding is that a lot of autoimmune patients may start by going what's called paleo. They tend to maybe avoid grains. All of us should try to minimize simple sugars, simple carbs. And then they will eat some grass-fed or more organic meats as their protein source, because some people initially may be a little more sensitive to beans. And so I think that may help some patients based on what their food intolerances might be. And again, distinguishing between food intolerance and food allergy is super important. Food allergy is where you have a true allergic IgE mediated response. People get hives, people get swollen lips. You obviously don't want anything that looks like anaphylaxis, where your throat feels like it's swelling or your eyes swell shut. Those are allergic responses. That's different. Whereas food intolerances can be sometimes immune mediated, and sometimes it's more other things are mediating it. You may not have the right digestive enzymes, for example, to digest beans. So taking something like Beano can be actually very helpful for a lot of people.
Take Beano before, there will be no gas.
And so I think it gets confusing. I think that food intolerance is something that is not necessarily a fixed state. People need to kind of do their N of 1 experiments where they can eliminate certain foods, try to understand that, and then very methodically reintroduce foods kind of one by one to see if their reaction occurs or not. And sometimes these reactions can be mitigated, like I said, with enzymes like Beano. Sometimes it's a matter of restoring the gut microbiome. So eating more probiotic foods, things like fermented foods, can be very helpful. Sometimes it's a matter of healing the gut lining. One thing that can be very helpful there is called L-glutamine. And so that can also be very mitigating. And so what can happen is that food intolerances can sometimes be overcome once you start to really heal your gut and improve your gut health. So I think it's not necessarily always a fixed reaction. But indeed, I think this is a complicated problem because a lot of our autoimmune patients just have these very hyper-responsive immune systems. And so when you have a leaky gut, you're basically exposing your immune system to, it could get activated and triggered against different bacteria, against different food antigens. It's a very complex, galaxy of things going on. And so I think that's where we have to be, I ask my patients to do N of 1 experiments and really pay attention to what their trigger foods are. Mm-hmm. And then, really try to understand if they re-challenge, is it a true reaction? Once they've kind of healed their gut more, do they have a true reaction? Is it an allergy? Hopefully not. But sometimes these things are mitigatable.
And can you tell me more about the Stanford PLANT study that you've done and the impact it's had?
We were excited. I have some very wonderful like-minded colleagues. I want to give a shout out to Neha Shah, who's a rheumatologist. She's an integrative rheumatologist. And then Dr. Mary Mikowski, who is a PhD in nutrition, and she works with the WellMD program here at Stanford. And so the three of us got together and were very like-minded on the fact that in medicine, we do not talk enough about nutrition and diet and the healing role that it can have. So we came up with a study. It was a randomized delayed intervention nutrition education study. We called it the PLANT Study. PLANT stands for Providers Learning About Nutrition Together. And it was very exciting because we basically said we want to actually study the providers, the healthcare providers that are physicians, that are advanced practice providers, dietitians, even trainees. Within less than a month, we recruited over 100 providers, 102 to be exact, who joined our study and signed up for a 6-week-long nutrition education program. And essentially we did weekly sessions that were about an hour, hour and a half. We had Christopher Gardner, who is of course a luminary in the field of nutrition. He gave our opening lecture. I actually gave a talk on sustainable diets and the importance of diet and nutrition and our planet. And Neha and Miriam gave some wonderful talks as well. And then we even had culinary medicine. We had a couple of cooking classes that we incorporated. I think a lot of the issue when we think about dietary barriers towards moving towards more plant-based diets is people don't really know, how do I do it? How do I get started, right? I think meat has become such an ingrained part of our culture, and learning how to cook more plant-based is super important. So our idea was that if we could try to teach the teachers, educate our healthcare providers who each have huge impacts. If you think about this, you do the experiment, do the mental math, each provider on average sees about 1,000 patients a year, let's say. And each patient eats about 2 to 3 meals a day. And if you do the math there, that's close to 1 million meals a year that one provider could influence. And it's really interesting. You'd be shocked that in medicine, we do not get a lot of nutrition training. I think it's like a quarter of medical students get the minimum 20 hours of nutrition training.
20 hours like in their whole
medical career, which is crazy. It's so foundational to medicine, and yet it is often overlooked. Thinking about this, I think there's such an important impetus to educate our medical providers, right? This is such a critical intervention that we need. So we decided that this approach could be very high yield. We had these 6 weeks, Group A, week 0 to week 6, Group B was week 6 to week 12. We took our primary endpoint at week 6, looking at readiness to change. So people's mindsets on changing towards a more plant-centered diet. And our results were striking. It was really clear that just by having this education, providing a little hand-holding and practical tips and tricks and the rationale for why this is important, really moved people, really influenced all these healthcare providers. And we were so excited. A lot of them, they wrote to us and said, thank you so much for providing this education. We loved this course. It was so inspiring. And they really wanted to see this, again, scaled up and if we could do this more broadly. So that's what we're currently working on right now, is how do we most effectively get the message out to a broader audience? Obviously, in our pilot study, it was a small group. It was 100, reasonable group, 102. We need more males. We didn't have as many males that signed up, so we need to think about that. We need to consider also how busy clinicians are, so we want to maybe try to compact it into a shorter time frame. But nonetheless, I think the concept holds true that if we can influence our healthcare providers to make sure everyone does talk about diet, and even if you don't talk about it in depth, but just simply by mentioning it. I get comments from my patients and they say, Dr. Katsumoto, you're the only doctor that talks to me about diet. And I'm just thinking to myself, that's really unfortunate that I'm the only doctor. Why is that? That shouldn't be the case. And then as I follow up with them over time, so many of them listen to, again, it's based on this personal relationship, this personal connection, this trust that we build. And they come back to me, and so many of them have told me I've really started to cut out or decrease my red meat consumption. I educate my patients on how harmful red meat is for the environment, and they listen and they get it. Starting to connect the dots between what we eat and how that impacts our environment, how that impacts climate, environmental degradation, all of these things.
So I get the question about plant-based meats a lot, and here's the relative carbon impacts of various meats versus plant-based meats. And you can appreciate that plant-based meats have a 36-fold less carbon impact compared to regular meat. My patients ask me, well, but these are processed foods. And this is where it's challenging because plant-based meats, they're not soda, they're not candy, they're not Twinkies. It's helpful to refer to the swap meat study by Christopher Gardner, which showed that there were improvements in lipid profiles of people that ate plant-based meats compared to regular meat. And they basically have no cholesterol, they have similar amounts of protein, and they have fiber and other nutrients that regular meat doesn't have. So basically, I wanted to say, if you choose a burger, you feel a hankering for a burger, I would recommend choosing a plant-based burger.
I give a little mini lecture when I talk to my patients in our sessions, and it's really inspiring how they react positively. I think a lot of physicians are scared. They don't want to offend people. They don't want to feel like they're being judgmental. But I have been so wonderfully, positively surprised at how people are grateful. People are thankful that I bring this topic up, and they feel open to talk about it. And obviously, you meet people where they're at. Some people are like, nope, not going to change, fine. But some people are like very curious. A lot of them, it turns out, they're like, I would like to eat more plant-based, but I don't know how to cook beans. You learn, like, there are certain skill sets that are easily fixable, easily mitigatable. You just exploring, asking the question. And even just the fact that if a physician asks the question, even if they don't know all the answers, it emphasizes and underscores how important that is. And patients pay attention. And then they can easily be referred to a dietitian or someone that's more knowledgeable. That's the message we want to get across to our healthcare provider community, physicians and advanced practice providers and whoever else is patient-centered. That could go a long way in terms of encouraging people to start shifting towards a dietary pattern that is plant-centered, which has so much data behind it for helping our human health and helping our planetary health.
Absolutely. And a lot of people don't know about the concept of bioaccumulation and that leading to a different level of contaminants in plants versus animal foods. Can you share about that?
So you've hit on a very, very interesting and important topic. One thing that I've come to appreciate is how important our environment is in influencing our health. And obviously, I care about climate change is very real, environmental degradation is a problem, and pollutants are a growing concern as well. I think in the news, we're hearing about plastics, we're hearing about PFAS, forever chemicals. One thing that has also caught my attention are persistent organic pollutants that are also in the environment. And persistent organic pollutants, a lot of them are endocrine disruptors.
Hi, it's your friendly video editor. When Tamiko dropped the term endocrine disruptors on us, spoken like a true scientist, I wondered how many people would want to Google that term. But no worries, the dietitian Abby Sharp has got us covered.
Endocrine disrupting chemicals, or EDCs, basically can change the body's function by mimicking, blocking, or interfering with the body's natural hormones. And this is not fake news, folks. This is a legitimate threat.
Some people call them hormone hijackers, and a lot of them hijack the hormone insulin, predisposing us to diabetes. Not what Americans need right now.
These are chemicals that are used for industrial processes like polychlorobiphenyls. There can be things that are byproducts of industrial processes. Things like dioxins end up, believe it or not, our hospital creates a lot of waste. Some of that goes into landfill. Some of it gets incinerated. And that can end up giving off things like dioxins, which is a huge problem. Learning about pesticides, so organochlorine pesticides in particular are considered persistent versus organophosphate pesticides are less persistent, but still problematic. These chemicals are in our environment. There was a Stockholm Convention that was convened. This was a treaty, an international treaty, where they realized that these chemicals were causing substantial health harms. And so starting in 2001, they got together and made a list of the dirty dozen, a dozen POPs, persistent organic pollutants, that were really problematic. Since then, they've added a few additional ones. Unfortunately, it's not all encompassing. So the other problem is a lot of these persistent organic pollutants, they persist for years, for decades. So even if you ban the production of them, let's say back in 2001, they may still be around in our environment. The good news is they're decreasing. When you measure these persistent organic pollutants, they're decreasing, but they're still present. And the problem is they are lipophilic, meaning that a lot of them are fat soluble. And that's one of the characteristics that makes them so persistent. They can end up building up in our fat. They can end up building up in the fat of animals, so animal tissue. And so just simply by thinking about the properties of some of these chemicals, the bioaccumulation potential, the fact that they're so lipophilic, meaning fat soluble, I think we need to be thinking about the fact that animal products tend to have a higher proportion of these chemicals in them. That's one thing that I think the community should be aware of in terms of when we eat all this meat, we may also be eating things that we don't intend to eat. Some of these chemicals like dioxins, even at tiny, tiny doses, they can be very problematic. and they can bioaccumulate. And so if we eat them, they can stay with us for years. I mean, I think we are seeing more and more issues in terms of thinking about California, and we have wildfires and a lot of these chemicals that are being released into the environment from urban fires, for example, versus forest fires. A lot of chemicals that are not supposed to be in our environment. So I think the problem is our food supply may end up having more of these chemicals than we appreciate. I would love if the EPA were on top of every single food item, but I'm worried that there may not be as thorough of a survey of our food as we would like. Thinking about more contemporary issues, more contemporary contaminants that we're thinking about, like the plastics. So plastics have things like phthalates and BPA or BPS, these various different chemicals in them. They also tend to be more fat soluble. And so when we're, for example, putting packaging on our food, the more fat-soluble chemicals may have a propensity to end up accumulating in fatty foods. And a lot of the more fatty foods are often the animal-based foods. These are things that are on my mind. And I will be honest, I think they've been under-researched. I think that we need to see more research looking into what's in our food, really doing detailed analyses of the components of our food.
Next up on The Sound of Sci, a new study says that chewing gum may release thousands of microplastics into the saliva. What? But I thought the raspberry-flavored wad of chemically extruded sneaker sole I was chewing was safe. And the hippies aren't immune either, folks, because the study found that even natural gums weren't plastic-free. But don't worry, they still taste like chewing Tom's of Maine deodorant.
I know there was a recent study we had connected about looking at different plastics and plasticizers that are in various food items. These types of studies need to be done on a more regular basis. The FDA, the EPA, these are agencies that we rely on, and I'm a little concerned about what's happening right now in terms of the regulatory agencies. They're being stripped of a lot of their manpower, so it's a problem. The issue of bioaccumulation is a big one that we should be paying attention to. I am a huge fan of eating to protect ourselves, not only for better health, but also protecting ourselves from these contaminants. There's a professor at University of Kentucky whose work I've been following. His name is Bernard Hennig. He is a brilliant toxicologist. He's put out some really interesting papers on the fact that plant-based eating, or at least eating more and more plants, can be super, super helpful to mitigate some of these toxicities.
My name is Pan Dang. I'm a postdoc working in Dr. Bernie Hennig's lab in UK Superfund Research Center. I think the most important and very exciting findings in our recent research is that eating high fiber diet can prevent the pollutant-induced cardiovascular disease.
By eating more different flavonoids, for example, that's a compound that can help detoxify things like arsenic. Or, for example, eating more sulforaphanes. Sulforaphanes are compounds that are high in sulfur. These are found in cruciferous vegetables. So things like broccoli and kale and Brussels sprouts, these types of foods, the deep greens. And sulforaphanes can help with glutathione, which is a system that our liver uses to detoxify from a lot of these chemicals. And so that helps our body clear these chemicals, which is really, really important. Finally, I think an important mechanism by which plants can be very, very helpful is not only do they have the polyphenols and a lot of these antioxidants and these incredible chemicals that are super helpful in protecting us, but they also have fiber. And fiber, including soluble versus insoluble fiber in particular, can help bind up a lot of these chemicals and will probably help with excretion of a lot of them. There was actually a very interesting cross-sectional study looking at, let's say, PFAS, for example, and they divided up people based on what quartile of fiber consumption they had in their diets. And what they found was a dose response. Those who had the lowest fiber consumption in their diets had the highest concentration of PFAS in their blood. And the highest quartile had the lowest PFAS. So whether that's a mechanism by which it's removal through the gut, you could argue, well, these are people that have healthier habits in general. But I think in general, I would say fiber is a known mitigation for a lot of toxins. We know that it can bind up things and help us excrete things. So I would say the answer to a lot of the toxins is plants. And again, I will just emphasize the antioxidants, the polyphenols, all these good compounds that are so important for bodily functions and for detoxification are found in plants.
And animal products don't have those, like the polyphenols and the antioxidants?
Not to the same degree. What do animals eat? They eat plants, right? I'll say this as well. One thing that is interesting is that, we talk about pesticides and people say, oh, there's so many pesticides on plants. The tolerable levels for pesticides are different for animal feed. So for example, soybean that are used for animal feed, you're allowed to have higher levels of pesticides used on those soybeans than you are on soybeans that are used for human consumption. And then of course, organic is always a good choice if you're able to do that. But I think the point is then, so the animals are eating these more pesticide-laden plant products, and then they are accumulating them. And so you may get some polyphenols when you're eating animals, but again, it's better to go straight to the plants.
Exactly, the source.
Go to the source.
Cut out the middleman.
Exactly, that's right. We need to be more cognizant of how we're farming. I love referring my patients to EWG.org. So EWG stands for the Environmental Working Group. They have really done a great job of really trying to vet what does our world look like in terms of contaminants? So they've got the Dirty Dozen, which is the 12 fruits and vegetables that are thought to be the most highly contaminated based on their testing with pesticides. These tend to be things that you eat directly, you eat the peel, so like blueberries and strawberries, things like that. They have the Clean 15, the produce that tend to often be less pesticide laden. A lot of times they're things that you peel, like bananas or avocados, things like that. So I encourage people to look at ewg.org because they've got great information. The other cool thing they've got is a tap water database. So a lot of times in clinic, I will ask patients, what is your zip code? And you can quickly look up by zip code what the tap water looks like for the area they live in. And they've profiled the contaminants, and you'd be shocked. If you look at, for example, Central Valley, there's just higher levels of contaminants there, which is concerning. And so thinking about how you want to treat your water with a carbon filter, or even the best would be something like a reverse osmosis filter. But just thinking about that to try to minimize the toxin exposure that people have. One other thing EWG has that I think is very helpful is they've got this whole catalog of personal care products that are used. This goes beyond food, but thinking about another source of exposure is a lot of the cosmetics that people are using, or sunscreen, or things that we're putting on our bodies that can be problematic in terms of parabens, which are endocrine disruptors, things like that. And so I encourage people to check out ewg.org because it's just an incredibly rich resource. I really appreciate the work that they do.
Yeah, thank you for sharing.
Absolutely.
And as a rheumatologist, what would you say is the impact of climate change on rheumatic diseases?
That is a very important question. Some colleagues and I recently wrote a scoping review on this because we wanted to ask exactly that question. Climate change is impacting health in so many different ways. Autoimmunity is complex. I think it's very multifactorial. It's a little more insidious. Autoimmunity is, there's multiple hits that it takes to develop autoimmunity. But when we did a search in the literature on climate change, so I'll give you some examples outside of rheumatology. So we know the more obvious links are wildfires are causing problems with pulmonary diseases. So worsening asthma, worsening COPD and lung disease. It turns out that our autoimmune patients can have what's called interstitial lung disease. So one might imagine that wildfires caused by climate change could have bigger impacts on people that have interstitial lung disease. Other examples, I think that air pollution obviously also causing a lot of inflammation. We're learning that air pollution can lead to worsening heart disease, so cardiovascular disease, stroke, lots of other health outcomes can be affected. And so in the field of rheumatology, the unfortunate truth is that the literature is very limited right now. There has not been a lot of focus on climate change and direct impacts like extreme weather on how it impacts our diseases. The most well-studied impacts have been air pollution, and there's been some information on temperature change, extreme heat, extreme cold. Air pollution is a big one because there's been a lot of nice time series studies where they've looked and seen that when there's bad air pollution days, you can have more flares of our autoimmune diseases like rheumatoid arthritis, like lupus, even gout can flare. Gout is, again, an important disease that's growing in incidence and prevalence, and I think climate change may be fueling a lot of that. Hurricanes and displacement and stress, eco-anxiety, all of these things are huge. Stress plays a huge role in autoimmunity.
And you've had some experience running large clinical trials and doing lots of research yourself in the past when you were a medical director at Genentech.
Yes.
I'm wondering if you could share more about what did you learn working there? How would you apply those learnings now?
Great question. So I spent about 5 years working at Genentech. It was an incredible company, very, very dedicated to the science. What was really inspirational to me was the ability to roll out these large clinical trials that had the potential for major impact for a lot of our chronic, complex diseases. And I learned about the importance of coming together in cross-functional teams. So, having people from all different disciplines come to the table and basically work very hard, very quickly to solve problems and roll out global clinical trials on a very short timeline. And so when I came to Stanford, when I first got here back in 2018, I recognized there was this increasing uptick of autoimmune complications being caused by immuno-oncology. So the oncologists using these immune checkpoint inhibitors were causing all these autoimmune side effects. So I learned that we needed a multidisciplinary way of getting at this issue. I basically formed a cross-functional team, brought together specialists from oncology, all the other different specialties, and came to the table, and we worked to solve this problem together and quickly. So that has been really wonderful now that we have a working group. It's called the Immune-Related Toxicity Working Group, which has really helped with patient care. Fast forward, in the meantime, as you know, Stanford has recognized the importance of sustainability and the environment in terms of how this is affecting planetary health is at risk, at stake. So just over a couple years ago, there was a wonderful donation from John and Ann Doerr to create a school of sustainability. I feel so privileged to be here at Stanford because Stanford's not just a medical center. Stanford is an entire university. It's an entire ecosystem with undergrads, with graduate schools of law, of business, of engineering, of the environment, in addition to medicine. What's happened is this school has come together and there's been a lot of discussions organizing around different themes. One of the themes that's popped up is food. In fact, I'm wearing a food jacket right now. And food is clearly a huge part of our sustainability problem and a huge part of the sustainability solution.
38% of all the land on Earth is devoted to growing food. We've done more by growing food to this planet than anything else we've ever done in terms of reshaping the very face of our world. So if 38% of the world's land is used for food, what's even more astonishing is that 29 of that is for the animal part of agriculture. Not just the grazing lands, but a pretty surprising amount of our cropland is used to raise animal feed. Food dominates the world, and animals dominate our food. It turns out that food and agriculture alone, directly producing food itself, is responsible for about 22% of greenhouse gas emissions. That rivals the entire emissions from electricity. It turns out the food system also touches many other sectors of the economy, contributing directly or indirectly to emissions as well. So not only growing food produces greenhouse gases, throwing food away does as well. And also the idea of cooling food, refrigeration, transport, cooking food, packaging food, all those little things. So yes, food production directly contributes about 22% of greenhouse gases, but the entire food system from farm to fork to fill and beyond, that is about 34% of greenhouse gas emissions, a third.
What's so beautiful is there's a ton of people that are interested in trying to get at this problem of food. And by working across the school, I've gotten to meet people in all these different schools, different backgrounds, different points of view. And by coming together, we have built incredible synergies. So I get to work with people like Christopher Gardner, who runs all these incredible diet intervention trials, but I'm also working with people like Jim Leap, and David Lobel, who are very focused on food security, thinking about developing countries. Roz Naylor, I can name just these incredible, incredible people. Deb Sivas, who's in law. So the fact that I am working alongside these brilliant minds, we're coming at these problems in a very cross-functional way. Again, coming back to my industry experience where I realized getting things done in this cross-functional, multidisciplinary way can be so much more synergistic, especially when you're tackling big problems like climate and sustainability.
When it comes to climate change, we usually think the most polluting thing we'll ever see is coal. If you burn a pound of coal, you're going to produce about 2 pounds, maybe up to 4 pounds of CO2 in the whole life cycle of producing coal-based electricity. But if I eat 1 pound of hamburger or 1 pound of beef, it's going to produce about 100 pounds of greenhouse gas equivalent. Beef is the most polluting substance you and I will ever touch with our bare hands, pretty much.
So I have to say, I feel so grateful to be here and to be in this environment where we have a very team-centered approach. And I'm very optimistic that a lot of amazing solutions are going to come out of this work.
Yeah, I love how you point out the importance of cross-functional collaboration. And at the Stanford Food Summit, where we saw you on a panel, you're with a lawyer and other physicians and scientists and researchers. And you made this really interesting comment which stuck with me. You talked about how some drugs like Ozempic get a lot of research and development, whereas traditional antibiotics don't get as much funding per se. And you kind of gave an interesting reason why. Can you share about that?
Good question. Drug development is complex. It's a high-risk, high-reward business. I don't know if you've heard the statistic, but about 90, maybe even 95% of drugs fail. They fail to pass through the whole funnel, starting from preclinical to phase 1, phase 2, phase 3, and then approval. There's a very high bar for efficacy and for safety. So they invest a lot of money into the development of these drugs. And so they have to think about, is the drug going to be used in a kind of episodic, one-off type of method versus in a context that's more chronic? And so you mentioned the example of Ozempic, which is a chronic drug, right?
I think Ozempic is the funniest thing, because like 3 years ago there was a vaccine and everyone's like, I ain't putting that in my body. And then they're like, it'll make you thin. They're like, what is this, for diabetes?
A lot of the drugs that we use for arthritis or for our autoimmune conditions tend to be more chronic. And so when they're calculating, how are we going to pay for all these trials, they need to factor that in. And so the issue, I think, with antibiotics comes that antibiotics are not used chronically, except for one example. They're used chronically in our animal agriculture system.
Oh, I didn't know. Yeah, that's a good point.
But they're not used chronically in people. From a marketing perspective, they need to think about, are they going to recoup their investment by investing in antibiotics? And so the landscape for developing drugs and antibiotics is less favorable, which is a huge problem. So let's talk about antibiotics. I mentioned that antibiotics are used chronically in animal agriculture. This is a huge problem. The reason they're used, one would think is, and again, we can talk about factory farming, we can talk about kind of how closed quarters, these are animals that are living in places where it breeds a lot of disease, not healthy, not happy conditions. So a lot of these animals probably are getting infections, but it turns out, I think what animal ag has figured out is by giving low doses of antibiotics, the animals grow faster. I think this is super interesting, and I don't know the data to support this, but I will say what's interesting is that the animals grow faster, they get fatter more quickly. They're probably killing off a lot of their microbiomes. And it's interesting as we draw parallels with humans and how we've lost a lot of our microbiomes as well. The links with obesity, we have to wonder, right?
Yeah.
And antibiotic overuse, things like this. I think that's an important concept. But the animals are given antibiotics chronically. In theory, they're supposed to withdraw the antibiotic before the animals go to slaughter. Doesn't always happen, but sometimes there are still antibiotics in the animals. And then we eat the animals. So that's another thing I think that needs to be measured more methodically, more extensively, is how much antibiotic are we consuming when we're consuming animal meat? Because I think that's also something that is of great concern. We eat them, and is it further killing off our microbiomes?
You're always a go-getter. I feel like you're speaking at like all these different conferences and working with so many different people. I'd love to hear more about just the current projects you're working on, in addition to, of course, being a physician, saving the world.
Oh, please. Thank you. No, so I think I'm so inspired by my patients. That's one of the big reasons that brought me back to academics and back to patient care, is I feel so privileged to take care of these lovely patients who have really taught me a lot. And so I'm always very, very humbled, recognizing the power that we have as clinicians, being patient-facing, the power that we have to influence people in a positive direction for their health, for planetary health, for all of the above. I mean, this is a win-win for sure. This is a win-win on multiple levels. I would like to really leverage that privileged position as a clinician, and scaling the plant study is really a priority that I have, hoping that we can spread the word in terms of teaching our fellow clinicians about the importance of diet. I think people know this, but I think we just need a little extra something to try to cut through the noise. There's a lot of noise out there, let's be honest. A lot of influencers, a lot of random, people think, oh, there's conflicting data, but what you eat really does matter. And I think there's a lot of very compelling data that eating more plants is a good thing. And so if we can kind of get the word out to a large group of healthcare providers, we're thinking already about scaling that, not just at Stanford in our little microcosm here, but I've got partners in the Central Valley that I'm talking to at a big health system there. I've got partners in different coasts and different areas. We have to pretty much go all over North America, in my opinion, global north, ideally, but we have to start somewhere. So I think my goal is to really optimize our educational intervention, providing tools that clinicians can use and access, and references for patients, right, to access as well. I'd like to be able to incorporate diet as a vital sign. We ask everyone about medications, we ask people about tobacco use and alcohol use. Why are we not systematically asking everyone about diet? If we could do this, you can imagine we can then study diet more systematically, and it would bring it up as an important topic of conversation that every visit should have. That's my goal, is to really try to change the way medicine is practiced. I've learned so much by prioritizing food in my patient encounters. Obviously, we talk about a lot of things, but when we do talk about food, I have been so pleasantly surprised at how fruitful that conversation is. I just want to tell my colleagues out there who are scared that patients may feel off-put or offended, I've had quite the opposite reaction. People are grateful, people are thankful that we bring it up, looking for answers. They have a lot of questions. Honestly, it's such a win. The amount of disease that it could prevent and the amount of disease that it could mitigate. I've seen it firsthand. I think there's so much data backing that up. Honestly, what could be better? So this is my goal. This is my big picture goal. Obviously, it's ambitious, but let's go big or go home. Let's do it. Yeah.
You said that doctors are the second most trusted source for nutrition advice. You had something of like, if doctors just knew that, they could affect thousands of patients. And I just wanted to get your thoughts on that.
It's so fascinating. There was a food survey. It's a very robust survey that goes out every year. And they asked, who is your most trusted source of information? And yes, nutrition scientists like Christopher Gardner were considered number one. And interestingly, physicians, nurses, healthcare providers were considered number two. You were absolutely right with that. What's weird is dietitians were lower on that. I found it kind of inspiring, kind of interesting and funny, because I mentioned also at that talk that we are not taught about nutrition in depth. We are trusted, yet I don't know that we're fully deserving of that trust, but I think the point is we need to fill the gap.
Me again. Those surveys are of Americans, and YouTube is telling us that only 50% of our viewers are American. We learned from our interviews with international nutrition scientists that their populations have much higher confidence in their scientists and dietary guidelines. And it shows in all their metrics, from obesity to life expectancy to the amount of prescription drugs they consume. When you look at nutrition science globally, it's amazing how closely actual nutrition scientists agree and have for 50 years. The key is the word nutrition in front of scientist. You hear of scientists like Neil deGrasse Tyson and Andrew Huberman who have various views, but they're not involved in actual nutrition research. Nutrition scientists are not the ones to listen to about space science, even if they dabble in it. And scientists who dabble in nutrition are not the ones to listen to about what to eat. There is a dark side in America to doctors having our trust in nutrition, because some of them who only dabble in nutrition exploit that trust and get rich by selling supplements, books, and brand deals. Peter Attia is Exhibit A, but there's a whole industry of doctors cashing in who are not involved in credible nutrition research. If you've actually been an actual scientist involved in nutrition research, you know it takes as much expertise as any other hard science. For example, imagine accurately collecting data for 105,000 health professionals over 30 years and having the big data expertise to unravel which foods get you to age 70 without a chronic disease and which don't. This paper in Nature was published by scientists in 5 leading universities across 3 countries to do that. And I'm not aware of any nutrition scientists who disagree with this paper. And what did they find? The items least likely to get us to age 70 healthy are sodium, meat, and trans fat. But I suggest a change to this chart of who Americans trust. I think we should lose social media influencers on the right and add physician scientists on the left, like Tamiko and Sean Spencer. If they truly know the science and do good doctoring, then I think they give the best advice because they have actual biometrics on you personally, while nutrition scientists only have population averages.
Clinicians in general, healthcare providers, are naturally people that want to do good in this world. They want to help others. They're science-driven, evidence-based, and so nutrition just falls right into that bucket. What's exciting is that a lot of patients want to know more. They want to eat more sustainably. What was it? 78% of patients change their diet based on conversations with their physician.
78%?
78%
that was from that same
based
survey?
on one, it was a different survey, but there's a paper backing that up. And I can personally attest to the fact that when I talk with patients about diet and then I do follow-up conversations with them, a lot of them do mention that they've made changes. They listen. And even if it's incremental, let's try incorporating a few more fruits and vegetables into your diet. Let's try swapping out that white rice for brown rice. Let's try eating less beef. It's been striking to me how many people end up making those changes. I mean, maybe they're just saying that to pacify me, but I actually really do believe that they are making changes and they are really trying. And in those who are really dedicated and really committed, that go even further, like I said, I've mentioned to you people that really move towards plant-centered, almost plant-exclusive diets. Some of them have had substantial improvements in their arthritis and in other health manifestations, which is incredible. And so, as I was saying with Michelle, if you do the math, you think about the numbers of patients that each of us clinicians interacts with, and that just can be multiplicative in terms of the impact it can have.
Oh, it's huge.
Obviously, I feel like there's been a lot of impact when people are sick, they want to get well, so they're super motivated. And that's also a helpful angle to have people that are like, what can I do to get better? I have a lot of patients who ask me, how do I get off medications? And I say, well, what do you want to do? Or do you want to talk about diet? Do you want to talk about lifestyle? That's like a perfect opening for these types of conversations to occur.
I would assume it takes a lot of time to teach people about diet and nutrition.
There's a lot of issues and challenges with our medical system, and time is one of them. I'm grateful to be here at Stanford, where I do have 30 minutes for return patients and 60 minutes for new patients. I like to get into these conversations. I think there's been some really interesting ideas that the American College of Lifestyle Medicine and others have put forth. One thing that is gaining more and more traction are things like group medical visits. So this is something that my colleague, Dr. Neha Shah, does this regularly. I'm actually going to hopefully start doing this soon. If we can have group medical visits where we bring a small group of people together to discuss a topic, let's say diet or any of these other lifestyle approaches, that could also be hugely impactful. Not only is it a more efficient way of disseminating information, having questions and answers that everyone can hear and learn from, but it also provides that sense of community, being in a group, being part of a group that people may feel more accountable to the group, right? That is going to be an important solution moving forward. The other really exciting thing that is gaining a lot of momentum are teaching kitchens. There's been a movement of people like dietitians and physicians partnering and really creating time and space for teaching patients about how do you cook.
My name is Isaac Karachapon, and I am the chef here at Stanford Hospital. I'm here today to make an immunity-boosting salad.
How do you cook a healthy, plant-centered meal? The pandemic was interesting because it forced a lot of us to learn how to work remotely. And with remote work, anything is possible, right? People can log in from anywhere. You don't need to physically come somewhere. You don't need to physically go on site to a kitchen per se. You can have a session from one's own kitchen, have patients in their own kitchens, and have a very interactive kind of hands-on session.
And now I'm going to cut this ginger about that thick, about 1/8 of an inch, so that way the ginger gets a chance to pick up the vinegar as a marinade.
Do you have any stories of somebody that has made those changes and seen good effects from it?
Lots of stories. I have had people whose arthritis has gotten better. One of my patients, she was coached by a nutrition professional, and she had a disease called scleroderma and myositis, kind of an overlap. And her disease, I didn't think it would get better. It did. Her muscle enzymes normalized. I was just like, what? So, I remember there was one day also where I had 2 young women who came into my office, and they both were like they're part of the whole fitness crew. And they're like, I was told I need to eat 1 gram of protein for every pound of body weight. And I'm like, whoa, this is the word on the street, right? And they were in serious pain. They were literally, their joints were hurting. They were a mess. I said to them, I would consider really switching towards plants and then eating more of the plant proteins. And by cutting out a lot of that meat, especially the red meat, they got better. The whole fitness world that's trying to push meat on people, I'm so curious how many of them are struggling, how many of them are getting joint pains, not to mention constipation and all the other issues that may come with that. These are real issues. So I worry a little bit about the influencer voice being so strong, because this information, I have yet to find a robust randomized controlled trial where it shows that the carnivore diet helps any health outcome. I have not found that. And we definitely have, how many decades and decades of experience speaking to red meat causing problems with vascular disease, cardiovascular disease. There's so much data pointing towards the converse being true. It does concern me that the influencers could sway people towards these meat-heavy diets. And we didn't even talk about gout, for example. Gout is something that we also see in our clinics. Uric acid, which is a byproduct of purine metabolism. What happens as people are eating, and we're eating a lot more ultra-processed food, a lot more meat, which is a problem. When you look over the past 100 years, the past century, meat consumption has just continued to go up, and it is highly concerning. As our health has deteriorated, right? As we're seeing more and more of these chronic diseases of obesity and diabetes and heart disease and a lot of other things as well. Gout is something we're actually working on a review right now where we're seeing this increased uptick in the incidence and prevalence of gout. And one has to believe that our diets are also contributing and fanning the flames of this increase, in addition to various environmental exposures, right? There's multiple factors, but I think these things are all kind of working in concert to fuel inflammation, which is fueling so many diseases.
What percentage of your patients do you think could benefit from nutrition, and which percentage of your patients do you actually talk to about nutrition?
100%. So
that's a pretty good score.
That's a pretty good score. Okay. So my belief is everyone can benefit. There are certainly people who have already very much, and again, I'll say, there's no one perfect diet for everyone. It's a bit of a moving target as well. And I understand that autoimmune diseases are multifactorial. But I think diet can play a big contributory role in pathogenesis. And so there are a group of patients who I feel have very much optimized their diet, and then we start looking at other levers. I prescribe medications. But what I do like to do is prescribe medications and then optimize their diets and then see if we can taper off meds. I love sort of these N of 1 experiments where you can say, okay, are we there yet? Are you in a new homeostatic level? You're stable. Can we then gradually start titrating down things? That always makes me very happy. Can everyone benefit from diet? Clearly, there are probably some diseases that are very genetically driven. I think in the pediatric world, much more genetically driven diseases, early manifestations of disease. But I still feel like diet could help in certain cases. In terms of who I talk to, I do bring diet up with everyone. We always have to be mindful of the context in which we talk about diet. We need to be sensitive if, for example, there's a concern for eating disorder. So if there's someone who is very controlling and is like, I'm just gonna eat cabbage, or I'm just gonna eat, no. Like we need to, again, the more plants you eat, the better. In fact, one thing I might not have said earlier is the American Gut Project showed data that a goal should be 30 different types of plants a week to really maximize the gut microbial diversity. So I think that's a good goalpost for everyone to aim for. And the reason plant-based eaters tend to achieve this goal more frequently is because they're not filling up on meat. They're really going for all the different plants, right? I do talk about diet with everyone, but I'm more reticent and I don't push it so far if the patient's like, no, I'm not interested. I'm not going to change my diet. I listen. You always have to feel that out. I have to respect people's boundaries. I always respect people's cultural backgrounds, traditions. I get that. Of course, if someone is, for example, in a very critical phase of their illness, so I work with a lot of cancer patients. If they have cancer and are really not doing well in terms of they're really underweight, losing weight, whatever, very catabolic, I often will be more conscious about not talking about diet too much, eating whatever they want for calories. When they're in that type of situation, obviously you don't want to start talking about restrictions or changes. Reading the room, reading each patient's individual needs and preferences is so important. Sensitivities, cultural, personal, whatever. Understanding what their dietary sensitivities are. So there are people that have celiac disease, and so clearly gluten is not an option for them. There's a lot of non-celiac gluten sensitivity that I think we're still trying to understand better. So trying to really cater recommendations based on what they are capable of eating, because there's not a one-size-fits-all and what their own preferences are. But I would say in 100% of my patients, I do bring up diet. And it has been a positive experience for the most part.
That's great.
Yeah.
So can I tell you about a project that I've been working on?
Yes.
So this was partially inspired by you, by the way. So I'm going to tell you how that all comes back together. Since I saw you last, I decided I want to bring health and nutrition to my gym. And the gym owners were like, great, because everybody asks about nutrition and we just tell them, I don't know, like just come to the gym and work out hard. So what I did is I took everybody's biometrics in the class. This was 27 people. And we did lipid panel, glucose, blood pressure, and weight. And then for 5 weeks, I taught them nutrition. At the end, I did their biometrics again. A standard statin dose would reduce LDL cholesterol by 20 to 30 points in this population. We dropped the average LDL cholesterol by 18.5 points.
Amazing. Congratulations. Did you do dietary surveys pre and post?
I didn't do dietary surveys, but I had everybody track their meals. So I have pictures of what they were eating and I could see the progression.
Awesome.
Not everybody was complying completely, of course. There were a couple people that did comply like almost 100%, but it was all about making improvements no matter where somebody was. One guy was like, hey, I ate McDonald's for just about every meal and now I do it once a week. That was the kind of progression we saw and it was so cool. So cholesterol came down. 5 people had high glucose at the beginning of the class. By the end of the 5 weeks, no one had high glucose.
I love it.
Yes.
Congratulations.
Yeah.
That's amazing. You know what? How can you scale that?
So now that you say that, I decided I'm going to create a company off of it. So that's my background is I created another software company and made it really big. So I don't need to work on making a business about money right now. I wanted it to be about health.
Yes.
And that's why I'm involved in Viva Longevity because I care about health and the planet. I want to create a tool for doctors so that they can say, hey, there's this program that you can do. It's called evidence-based nutrition. You get on it for 5 weeks. It might help your cholesterol. It might help your weight, whatever it is. So I'm creating this, and that's why I want to make sure I make something that doctors can use and would feel comfortable prescribing to patients. So I was wondering, do you have any thoughts on what I need to do to make sure doctors would feel comfortable using it, and how do I talk to more doctors?
Yeah, no, I mean, I think this is wonderful. What I love about your intervention is you're targeting a population that has traditionally been more challenging to target.
Really?
I'm guessing you had a more male population. Is that true or no?
More females participated.
Oh, more females participated. Okay.
But there were still plenty of males.
And what was the age range?
They were a little bit younger.
Yes.
Yeah, these are 30s, some in their 40s. We had 1 or 2 people in their 60s, but that's it.
Yes. So what I love about your intervention is you're targeting a segment that is often healthier, not in our clinics. They're in the gym, right? And they are listening to all the, you must eat meat as protein. And I feel like that's where we can make a big impact. So I think this is a very complementary intervention because, like I said, a lot of these younger, healthy people aren't showing up in our clinics because they're not yet sick.
Yeah.
I mean, they're on the road to being sick as they're building up plaques in their arteries, right? As they're literally moving down that road. So if it's an intervention that has data, which it sounds like you're showing that this is effective, clearly the intervention worked well, I think there'd be a lot of clinicians that would be interested in referring people. For sure. But I think we need to think outside the box in terms of, like I said, different, so I'll just mention one paper that said 50% of our red meat consumption is driven by 12% of the population.
Really?
And what do you think that population was?
The gym goers?
It was males. I think the age was actually like between 40 and 60. Don't quote me on that, but it was very male. And so if we can get at that population, that can move the needle even more impactfully. It's difficult.
Yeah.
It's difficult. I have talked to people who said, I'm sorry, I grew up eating meat and potatoes, I'm not changing. To be honest with you, it is harder to change when you're older. And I think as clinicians, we often do tend to see an older segment of the population that tends to be sicker. So I'm super excited about your idea because if we really want to make impact, we've got to target the younger folks.
Yeah. And what I would do with those circumstances, because I also kind of did coaching along the way, is whenever somebody was like, no, I love my steaks or I love my ice cream or whatever it is, I would say, great, we're going to keep that in your diet. So let's make the other changes that will make the biggest impact so you can keep eating that. And what I would see is they would make those changes and that other thing that they said they wouldn't let go of, they'd bring it down. And I never had to tell them to bring it down after that because they just kind of started saying, oh, I actually kind of like that hummus dish the other day. I'm gonna have that again.
That's so awesome. That is so awesome. And as we increase our fiber intake, then it leads to more satiety and then we have less of the cravings for more calories from other things.
Yeah.
I love it. Hummus. That's so cool.
Everyone in the class said that it was sustainable. They felt like they could keep doing it.
That's amazing. And that is so critical. If you come in from, thou shalt give up, blah, 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 thou shalt be vegan. Again, those messages often are not well received.
Yeah.
But I love your idea, what Christopher Gardner terms like stealth nutrition. What you crowd out a lot of these other foods and you crowd in a lot of these good foods.
Yep.
I think that is the secret sauce to really affecting change, making it very palatable, making it very feasible, easily obtainable, teaching some basic skills to change our habits.
And I try to provide lots of good resources so here's all the restaurants in the area, here's some meals that you can buy online if you want to just have your meals prepped for you. So
yes, and that's a whole area where working with Christopher Gardner, and he has a huge interest in food systems, food institutions, thinking about the Stanford Hospital or thinking about Google or thinking about schools, thinking about jails. Can we systematically change some of these large food systems to really move more plant forward? I know there's a great nonprofit called Greener by Default where they're making the plant forward, plant centered meal the default, and that you have to ask for meat. Or they're making meat really the side dish or the condiment, and they're making the plants the centerpiece. I think there's a lot of these strategies that could be very effective. I recognize one of the barriers, especially for busy clinicians, is they don't have time. They don't have time to cook and prep and all this other stuff. So we do need to change the institutional food systems to make it easier, to make the healthier choice.
Yeah.
So I
love that.
Yeah, it's so important.
Yep. Let's get the whole society moving in the right direction.
Exactly.
And people will be happier with it. It sounds like it's restrictive, but really what it is it's giving them more health and they're going to be happier with it.
That's right. And they'll feel better and there's just feed-forward effects. And honestly, for me, it's also helping mitigate my eco-anxiety. I think there's a whole issue, a lot of people, there's now a majority of people who are very concerned about the environment and about what's happening in our world with climate. People may not talk about it. In fact, it turns out a lot of people don't think other people are worried. They think they're just the only, they're just kind of keeping it to themselves. But I think we need to talk about these things. And I think what's so impactful is giving people agency by informing them that the choices they make can have a huge impact on the environment. And that helps me so much in my daily life, just feeling a little less guilty about my environmental footprint. Like, okay. I mean, it's hard. We're all using resources. I think we haven't yet figured out a fully circular economy and a fully sustainable way of living. But as we're making those steps, I know that food is so important to solving this equation.
Yeah.
I mean, it's thought to be a quarter to even a third of our overall greenhouse gas impact when you think about everything, all things considered. So this is such a win-win to focus on food.
And it's so interesting because when you ask people, they say, oh, well, corporations need to fix this. I can't do anything about it. I'm just an innocent bystander. But it's nice to feel empowered, like I can actually make some changes just by what I do every day.
Exactly. It was interesting. In our plant study, we did a survey of what do you think were the most important things towards moving towards a whole food plant-based diet. It turned out the biggest reason was my own health. My own health was number one. I think 90% of people agreed that was the biggest reason they did it. So clearly that's an important driver. Loved one's health is another important one. But climate was the third. Climate and environmental sustainability was the third. Everyone's going to have a different reason. In our group of people, religion was very low on the list, but that's going to change and be different. For some people, it's animal welfare, right? But regardless of what your reason is, there's so many good reasons to make these changes. I personally feel like if we really highlight the role it plays in health and well-being, that's why I lead with the Plants for Joint study and arthritis. And I do like to cite Dean Ornish's study on dementia because everyone is scared about losing their memory. And he showed compelling data in a short time frame, which just blows my mind. It was a big score. And so these are things people are concerned about. Arthritis is really impactful because 1 in 5 people has some type of arthritis. I think we've all dealt with some sort of joint pains here and there. It's really meaningful to say there's something you can try to do to mitigate this. We just have to keep spreading the good word. I love what you're doing. I'm so excited to partner with you and think about ways we can all partner together. I'm such a big fan of building community and have been so heartened to see how many like-minded people there are. Here at Stanford, I've found my tribe of people that are also like-minded. I've been giving grand rounds at other institutions around the country and have been very warmly well received, have heard a lot of words of support. People that say, doctors that say, I'm starting to change my diet, which just makes me very happy. We're all in this together, and I think we can all be part of the solution, which is what gives me great hope.
My big takeaway from the interviews with Sean and Tamiko is that the microbiome acts like organs, such as kidneys or the pancreas. If you lose enough kidney or pancreatic cells, you end up in dialysis or on insulin. The microbiome is like that because if we lose species, maybe from antibiotics or a low-fiber diet, the foods we were once able to digest and were good for us now cause bloating, gas, and inflammation because the species that made digesting fiber easy are no longer in us. As we were walking across the campus after the interview, Sean mentioned that he has a couple of patients who tried the carnivore diet for a few years and now are trying to go back to the diets they once ate. But they haven't been able to. They didn't bank their poop for a future fecal transplant prior to trying those diets, so it isn't clear if the fiber-loving species they once had in their guts are ever coming back. And if they become mothers, their infants will inherit their carnivore diet microbiomes. I love old nutrition books. Here's one from 1652, which I cherish, with some wisdom of the ages we Americans could really use right now. What's really fascinating to me is the repeated rise and fall of zero-fiber diets. The carnivore diet has been popular 5 different times in America since the mid-1800s, and I've read all the books that started those movements. I can't even count all the times the milk diet has been considered miraculous, or the egg diet. Just think of how incredibly popular Vince Gironda's steak and egg diet was starting in the 50s, which hooked my dad. But I've never been able to find anybody who adhered to those diets for a sustained period of time and lived long. James Salisbury, who popularized the carnivore diet in the late 1800s, lived to 82, but that's about all I can find. Most of the others didn't make it out of their 70s. And I always wondered why that was. They weren't eating processed foods, they didn't smoke or drink. The wisdom of previous centuries was to eat the widest variety of food possible. Blackbirds, squirrels, wild greens, flowers, and berries. But not until 20 years or so ago have we known about the profound influence of the microbiome and the central role that fiber plays in preserving it. Maybe fiber's role in calming inflammation is a major factor in longevity. By popular demand, Sean is coming back to answer your questions about the microbiome and your poop. You've submitted 200 questions so far. If you want to be notified when that episode comes out, subscribe to the channel. I may be the only YouTuber who never asks for subscribers or likes.